The next case, thank you, Shivaranjani.
Thank you.
We will move to the next case, Bleached from Medicine 5, Dorene, Juana.
Good morning, everybody. I'm going to be presenting on behalf of Medicine 5. I'm going to be looking at Mrs. S. She was a 29-year-old female who had decided to clean her bathroom, and she had used bleaching powder, and then she decided to add acid for better cleaning effect. In less than 5 minutes, she had developed an acute onset breathing difficulty with chest tightness. She had no other symptoms, and she was immediately brought to CMC for further management. When she was brought here, she was noted that her heart rate was 100 per minute, her blood pressure was 120/80, she was breathing at a respiratory rate of 20 per minute, and her saturation was 88. In systemic examination, she had significant bilateral crepitations were heard in her infrascapular regions, and also scattered wheeze was heard. Her baseline investigations, her hemoglobin was 9.8, her total counts was 8,900, platelets was 2,53,000. There was no renal or hepatic dysfunction, and all her electrolyte parameters were normal. And ECG was suggestive of a sinus tachycardia. This was her X-ray. There was very minimal bilateral perihyar infiltrates which were noted. So what do you think happened? She had first used bleaching powder, and then on top of it, which we normally don't, but she had added acid, hydrochloric acid on top of it. So what had happened is bleaching powder is calcium oxychloride, and which when it reacts with hydrochloric acid, it forms chlorine gas. So which is what had happened to her. So the final diagnosis that in her was that it was a bilateral lung disease, parenchymal origin. The pathology was a chemical pneumonitis secondary to chlorine gas inhalation. So how common is chlorine gas inhalation? So in the American Association of Poison Control Centers had reported over 6,300 exposures of chlorine, which is making it the most common inhalational irritant in the United States. So even other than being a common household irritant like this, it was used also for its toxic nature in World War I, when it was first used by the Germans against the French people because of its toxic nature. And also because it's a pulmonary irritant, it was much widely used during the, and for its asphyxiant property, it was used in the World War I. Coming to the pathophysiology of gaseous chloride, it has an intermediate water solubility, because of which it diffuses both into the upper airway and also into the lower respiratory tract, causing symptoms both in causing like bronchospasm and also affecting the alveolar rhythm. The primary pathophysiology is it causes cellular injury resulting from oxidation of the functional groups in the cells, which releases this hypochlorous acid and also free radicals, which further act on the airway and causing the damage. Coming to the doses and at what dose of chlorine gas exposure the effects are seen. When the exposure is very limited to like 2 parts per minute, there is only eye or mucous membrane irritation. Somewhere between 9 to 50, there is symptoms of chemical pneumonitis and bronchiolitis obliterans. At levels of exposure of 200 parts per minute, there is extensive bronchial constrictions are noted, and anything around 800 parts per minute is considered lethal. So we looked at a few case reports which chlorine gas inhalation as to what all could be the maximum extent of injury and what should be watched out for. So this was a case report in the respirology case reports, which was looked at a 43-year-old woman. She had a history of intellectual disability. She had mixed rice vinegar and household bleach, similar to our scenario, where the bleach containing sodium hypochlorite, and she had inhaled the same. So after the inhalation, she had pain in her chest, and then which progressed to she started having dyspnea and also having wheezing and coughing. So when she was evaluated, her CT thorax had shown bilateral diffuse ground glass opacities and nodules in tree-bud pattern. So there they had given her ceftriaxone for 5 days to prevent any secondary bacterial pneumonia, and they noticed that her respiratory symptoms had gradually improved with even without the use of bronchodilators or corticosteroids. So after 3 days of admission, her SpO2 had she had improved to 97%, without any supplemental oxygen also. And 6 days after admission, her follow-up chest CT was almost normal. So note that in this scenario, there was no use of any bronchodilators, corticosteroids, or supplemental oxygen. This was another case report which looked at a 9-year-old child who had developed shortness of breath after playing with in a building site with where bonfire materials were being collected. And then he presented to the ER with just tachycardia, he was tachypneic, and on examination, expiratory wheeze was noted. Over the next 24 hours, he had progressively worsened, which requiring intubation. And post which by then they had found out that it was secondary to chlorine gas inhalation. So he was only kept on supportive management, and he was successfully extubated within just 48 hours. And he was given a 5-day course of steroids, and he was discharged within 5 days. He was later reviewed at the outpatient clinic 6 weeks later, and he was noted to be doing well. This is the third case series, which had looked at a 23-year-old man who presented to the emergency department. So there, 7 other more people were also involved after they had an accidental exposure in the community swimming hall. So he had cough, and subsequently he also had developed breathing difficulty, and he also was noted to be tachypneic and had bilateral wheeze was present. His CT had also shown there was ill-defined central lobular nodules and mild air trapping, and features which were consistent with diffuse bronchiolitis. The PFT his PFT was done, which was done 96 hours after exposure. It had revealed a mild obstructive defect which had a good bronchodilator response. This man was treated only with he was treated with supplemental oxygen and inhaled beta agonist, and he was discharged with inhaled albuterol MDIs and prednisolone dose of 1 mg per kg per day for a 4-week course. After that, he still continued to have mild dyspnea on exertion. But his repeat pulmonary function test, which was repeated significantly almost after 3 months, which had shown that there was improvement of his symptoms. So in an amalgam of all the 3 case series with different approach, there was a general approach to that we saw with chlorine gas inhalation is that it's mainly a supportive care. And the first priority comes to securing the airway and intubation or tracheostomy if necessary. The obstruction may also occur due to the airway reactivity. So in those scenarios, the bronchodilators should be used. Early or prophylactic antibiotic usage is not recommended as per guidelines, though there was one scenario where the boy was given ceftriaxone to prevent secondary infection. Use of steroids in either an inhaled form or an intravenous form. Few complications that can happen with the chlorine gases: a secondary bacterial infection, and either a barotrauma or pneumothorax when patient is on NIV or invasive ventilation, and very rare instantly that they can develop into a chronic obstructive airway disease. What we did for our patient was that she was only initially she required oxygen via face masks indeed, but when she came to the ward, she was maintaining saturation in room air. We had given her nebulization, beta agonist was given, and she was asymptomatic, so we did not give her any steroids. And we monitored her for 5 days, after which she was discharged. The take home is that chlorine gas in exposure, the common presentation has the cough, breathing difficulty with features of hypoxia or tachypnea on examination. The CT change, if there is a significant exposure, CT changes can be noted. And the mainstay therapy is supportive, and even the damage that is there in the that causes to the respiratory tract in most instances is reversible.
Thank you, Dorene. Your case seemed to have reversed fairly quickly. Yeah? What was the saturation in the ED?
88.
88, and by the time the patient came to the ward on room air, it was normal saturation. Interesting. Any questions or comments? Yes, please.
What was the chlorine level in this patient?
No, we didn't.
You're not checked.
No, we didn't check for the.
The serum chlorine levels have been described with exposure to chlorine gas.
So
and even hyperchloremic metabolic responses have been commonly described. Although we don't have large enough series to say that it is in fact a diagnostic marker or a severity marker. What do you follow these patients for? Do you do any follow-up at all? 5 days patient got better, or did you discuss on this day?
To review back with the, she didn't have it. We just asked her to review the repeat chest X-ray. Thing. We didn't ask her to specifically come back with any this thing. She
There is very good evidence to show that at least about 20-30% of patients have been exposed to more than 2 ppm of protein gas will develop obstructive airway diseases after a year. At the end of a year on yeah, this 20-30%. So might be prudent to follow their spirometry maybe after 6 months or earlier if she has symptoms.
So, Amit, the hyperchloremia occurs with a severe disease, is it? From what she said, what I understood was it kind of triggers the chemical pneumonitis, and the severe ones will become, the CTs wherever they have done. It shows primarily GGOs. I don't know whether some of them go into ARDS and severe clear features of ARDS. So it does progress on to become hyperchloremic.
We don't know what is the mechanism, sir. These are basically small case series or case reports that are described as hyperchloremia. It's possible that chlorine is getting absorbed systemically through the respiratory tract or even the skin. That is possible in elevated point.
Interesting. Thank you for that comment, Amit. Any other questions or comments from the faculty or anybody else listening from online? If there is none,